Well, welcome back, everyone, to another episode of the Rick and Danny Show. Rick, it's great being back.
Pleasure being back. Hopefully the audio has returned to normal after our Top Golf experience. I'd like the listeners to know that
That was a tough one.
I was the one in charge of the audio, so you can definitely direct your hate mail to me. Although Brenna set it up, so I don't know who.
I directed my hate mail towards you as I was editing it, but I think it came out, given the circumstances, it came out okay.
Yes.
Well, I just would also like to point
not
out
great.
that you thought we wouldn't get any audio at all from the event, and turns
Right.
out we got
True.
really good conversations with people that are hard to track down.
You were right. Is that what you want to hear?
I'm just saying it
Okay.
would be nice every once in a while to hear I did the right
Rick,
thing.
nice job.
Oh, thanks.
Strong work.
I appreciate that.
All right.
Near impossible not to have noise in that environment. It's
I had to
a
cut
fun
out,
environment with
Yeah.
a lot of things going on.
I had
So.
to cut out an entire spiel from Rick because someone was just screeching in the background,
Screaming,
and I was
yeah.
like, I don't have the
Yeah.
capability to
To edit it,
to edit it, so
Yeah.
I just
you 86'd
chopped
it.
it. Yeah.
I probably said some really smart things.
It was really great. I was really upset, but it was like,
It's too bad.
yeah, I'm sorry. I had to make an executive
So for the
decision.
listeners out there who've not done that event, please mark it on your calendars for next year. Probably be around the same time.
Yes.
I would imagine.
Yes.
So love to have you guys
third
out.
week, May.
Yeah.
Yes.
So it's a good time, a lot of fun, very low key, which is good.
Yes.
So Danny, your medical society had a pretty big fundraiser themselves.
My medical society, no. The American Society of Clinical Oncology. Yeah, it's a big conference in Chicago every year. They host it, and I don't think it's changed for more than 10 years. It's always been at the same big McCormick place in downtown Chicago. So it's always a time of year where lots of updates come in, and they talk about updated data on certain trials that have already been done, and then new data for a variety of different cancers. And it's not specific for clinical oncology or solid tumor oncology. It's also, there's some hematology presented at this conference, but I would say a majority of it is solid tumor data. But there were some good reports, some really probably practice changing data that came out of it. What do you think? Should we start out with the oncology side, then go into the radiation side, Rick?
We can do whatever you
Yeah.
prefer. What struck you? What was the most interesting thing you read or saw from the conference?
Well, I think, one of the probably talks that got a lot of press that I thought was long awaited was to see the adjuvant data for EGFR mutated non-small cell lung cancer, a drug called osimertinib or Tagrisso. It got FDA approval before there was overall survival data in patients with non-small cell lung cancer with EGFR mutations, which is a specific activating mutation that can happen in the cancer cells. And there are specific EGFR inhibitor pills that patients with these mutations can take to, treat the cancer independent of chemotherapy. The ADORA trial was done, let me see here, what years? I don't know. I don't have it on my abstract here, but it initially got reported, and I think the data that got reported was either progression-free or disease-free survival
I think
benefit.
it's progression-free, yeah.
Yeah.
Or maybe, yeah. The initial reporting.
Initial report, progression-free survival benefit with osimertinib compared to placebo in patients with EGFR mutated non-small cell lung cancer. Now, this group of patients were surgical candidates, so anywhere from, I think, stage 1B to 3A non-small cell lung cancer. They underwent surgery. They were randomized to either Tagrisso or no Tagrisso, but patients were offered chemotherapy, which is standard for those at higher risk of recurrence. And patients underwent usually 4 cycles of a platinum-containing chemotherapy regimen, and then they started osimertinib. Tagrisso is another name for that drug, following chemotherapy, and took it for up to 1 year. And initially showed that there was progression-free survival benefit, meaning patients lived longer without progression on the Tagrisso arm. but the long-awaited survival data was what was reported at ASCO. And I have the abstract in front of me here. It got reported in New England Journal of Medicine because it was such a groundbreaking article that will lead to how we practice medicine treating these non-small cell lung cancer patients. So the 5-year overall survival in the patients who received Tagrisso for 1 year was 85%. And that's compared to 73% in the placebo group. And they broke it down in different stages, stage 1B and the stage 2 and stage 3A population. Each group seemed to benefit from Tagrisso, although most of the benefit was coming from the higher stage 2 and stage 3 population. At least when you look at the statistics and the confidence intervals, seem like the higher stages benefited more. But this is really even more of a reason to offer Tagrisso to patients after they complete their chemotherapy. And it looked like you're at least looking at about a 10% benefit in overall survival compared to not giving it. So definitely we should be talking to every patient who has an EGFR mutation who undergoes surgery for their lung cancer about this drug. And it is something that's already FDA approved, but we can at least tell them now that data shows that patients survive longer in those who receive it. So what do you think, Rick?
Well, I think that was a very good summary of the trial. There's a lot of things about it that I think at least merit some mention of. There's some criticism of the trial in the sense that brain MRI staging was not mandatory, which is a standard of care when you see these patients. So there is some controversy over was the patients who were put on the osimertinib arm, if they had brain metastasis, were they being treated unknowingly, right? So
Right.
not true adjuvant therapy.
Because it has benefit in those with CNS metastases, and they wouldn't have been eligible for this trial.
Right.
But
And then the other controversy in my mind, probably the bigger point, is the fact that they didn't really allow crossover for 3 years. So I think, in my opinion, it would have been a standard of care at the time of this trial that if a patient developed recurrence, and they had the EGFR mutation, you would presumably give him osimertinib, right? And that was not allowed on this trial, or there was very strict criteria to get them to do that.
Right.
And a very few minority of patients who progressed in the placebo arm got it at relapse. So I think, to me, the real question becomes, obviously the drug has activity, obviously the drug is effective, it's a great drug, but is there really going to be a benefit to giving it to everybody adjuvantly versus if you surveil them closely and give it at the first sign of recurrence, can you spare some percentage of the patients from ever having to receive the drug?
Right.
So I think that, to me, those are the two, at least what I've seen, sort of arguments, not against the trial is the wrong word, but
right.
discussion points at least to have. But I think the drug clearly has activity. It clearly works. It's very effective. But like we've talked about on other episodes, this is not a metastatic setting trial. This is patients who presumably have no evidence of disease radiographically after a definitive resection. So the bar, in my opinion, needs to be, you need to prove a survival benefit if you allowed crossover. So that's why I think the trial doesn't answer that question. But to your point, I think because of the way the trial was designed and the results, it's going to be hard in your situation as a medical oncologist to recommend against it in patients that meet this criteria, despite those caveats.
And I think what's hard too is you have the clinical stages are anywhere from 1B to 3A, and you have patients who possibly in the 1B group who you wouldn't recommend chemotherapy to postoperatively. There's select high-risk criteria for 1B, and I presume that the trial looked at those high-risk factors for the 1B population, but the other issue is that Tagrisso was given sometimes in patients who never received chemotherapy, that chemotherapy was not mandated to complete 4 cycles before starting Tagrisso, that I think providers had the option of if they thought it was too high risk or the patients, had poor tolerance, that they could then start Tagrisso early before completing 4 cycles of platinum-based chemotherapy. So, I think you have patients that maybe, receive chemo who you wouldn't strongly advise them to get chemo. And then you have patients who didn't complete their 4 cycles of chemo and went on to Grisso. And so I think I'd like to have a trial showing, okay, if we're going to offer this to all 1B, stage 1B patients, there's a clear benefit there, because I don't think this trial was powered to show that. It's got powered to show that there is a benefit in the whole group, but not in the subgroups of 1B, 2A, 2B. So it's a little bit hard to interpret because the confidence intervals for those lower stage groups, were wide, and you can't make a definitive, statement that it benefits all patients in those stage groups. So, I think this is something you just talk to patients about and talk about the toxicity of the treatment. They have to stay on it a year. It's an oral therapy. It's not a cheap therapy. It's very, very expensive, probably more than $15,000 a month. And you hope that they have good insurance coverage and prescription drug coverage that can cover a majority of that. But, certainly you have to talk to patients about all those factors when presenting it to them. But the long-awaited overall survival data is out there and shows at least about a 10-12% benefit. So we'll move on from there. All right. Any trial that piqued your interest that
I think
you liked reading about from the ASCO?
The one that I think, at least on the radiation side, that got publicity was the Prospect trial.
Yes.
The rectal cancer trial.
Mm-hmm.
I think it led to some headlines that the New York Times had to edit in real time because they, I won't say, I don't know if mistakenly is the right word, but put out some headlines that were misleading, shall we say the least.
I think that's right. A lot of misleading information.
And that they had to edit, within a day of publishing, which is usually not a good sign. But basically, for the listeners, this was a trial of patients with very specific type of rectal cancers, so upper rectal cancer, so away from the anal sphincter, that had minimal nodal disease burden. And the question was, now for those patients, we would give a course of chemoradiation followed by surgical resection. The question was, instead of chemoradiation, if you gave multi-agent chemotherapy, could you achieve equivalent outcomes as opposed to low-dose chemotherapy with radiation? And what the trial found was basically that the outcomes cancer-wise were essentially the same between the two arms, with some patients getting additional chemo out back and 10% of the patients in the chemotherapy upfront arm also getting chemoradiation for various reasons, lack of response. There was specific criteria. So what they did is they basically said in the patients who got chemo, they gave them chemo, then reassessed radiographically, and as long as there was no progression and showing response, they continued on chemo and omitted the chemo radiation portion. Go ahead.
There was specific criteria that they had to achieve a response. I think it was 20% reduction in tumor burden and thickness. So they had to meet that criteria to omit radiation.
And so the overall results of the trial were that the cancer outcomes were the same between the two arms. And the study got reported, at least the New York Times headline was, study shows you can omit the brutal effects of radiation in these patients. That was the quote. What the articles did not report on is that actually the grade 3 and higher toxicity rates were double in the arm that did not get radiation.
Right.
So as you know better than I could explain, in patients who get multi-agent chemo, including oxaliplatin, neuropathy and other things are a big problem, which in patients who are just getting 5-FU and radiation, not as much of a concern. So in my mind, what this study, the way I would utilize it in my practice is for patients that meet this very specific criteria, you can have a discussion with them and say, here's the expected pluses and minuses of radiation. Here's the expected pluses and minuses of multi-drug chemo. In what you value, does one mean more than the other? And let them make a decision. But I do think the way it was reported was a little disingenuous, given the significant toxicity worsening in the multi-agent chemotherapy arm.
Right. I think, and nowadays, how do you view this in the era of total neoadjuvant therapy?
Right, and that's the real question is
Right.
in what we are now moving towards for a lot of patients, where you get the chemo radiation, then chemo, then surgery, all before. Where does this trial fit?
Right.
And to me, you're going to have to thread a very fine needle of patients that have this very specific upper rectal tumor with minimal nodal burden, but they're also high risk enough that you think it makes sense to give them multi-agent chemo. It's just not it's not the patient population I typically see. But yes, I think the data to me is much stronger in the total neoadjuvant space. And certainly that if I had a tumor like this, maybe even where I would lean, unless I had, really no nodal involvement or something like that, then maybe you pick your poison of one of the two. But yeah, it's hard to put it in context because I don't think it's not as generalizable as the total neoadjuvant studies.
Yeah, I would have almost liked to see it, compared to that total neoadjuvant regimen, right? You have your chemo RT and chemotherapy followed by surgery, and then compare it to this where you give chemo, and if you meet certain criteria, you just move on to surgery. But yeah, it's a little bit, from my standpoint, I don't think it's going to change much how I practice. I think I've moved toward patients who, if you have and we have T staging of tumors that tell us how much the tumor's growing into the wall of the rectum, and then you have your end stage, which is kind of how many nodes that lymph nodes you think are positive with cancer based on the imaging they had done in clinic, and you can kind of make a decision who's high risk, who's not. And I think definitely in the higher risk patients, we're going to do total neoadjuvant regardless. Those are the thicker tumors, the ones with multiple nodes. For a patient that maybe doesn't meet the high risk criteria, maybe would meet criteria for this trial. I'm not sure that a patient's going to necessarily prefer to get multi-agent chemo over low-dose chemo and radiation.
Yeah, it's hard to. I think if you presented the data objectively, I think most patients would not opt to do that. I would think
because the chemo is more toxic just based on the side effect profiles. You're going to have more toxicity.
And the other thing too is because these are upper rectal tumors, you're away from the anal sphincter, and so one of the the big concern with radiation side effects long term in these patients is the part of the bowel, the part of the rectum that you're giving radiation to is being removed surgically. So there's really no risk there. But when you have surgery and radiation for a lower rectal tumor where you're near the sphincter, what you worry about is symptoms of fecal incontinence, fecal urgency, things like that. In this patient population, that risk is much lower because where we're focusing the radiation is the tumor itself is higher up. It's away from the sphincter complex. So in terms of the long-term morbidity of radiation, these patients actually in general do very well, as the data bore out, because you're not really treating the sphincter complex necessarily like you would in a low-lying rectal tumor where you have to treat it because the tumor is there or involving or right next to it.
Right.
So it's also anatomically, there's some distinction there as well, which I think contributed to why, and this used older radiation techniques and all that kind of stuff. But even still, I think is why the numbers are, not as bad as the chemo, just because again it's an anatomical issue, which is just something else to think about. But yeah, I think it's good. I'm blessed that I work with medical oncology partners who look at things as a big picture as opposed to just reading a headline and assuming something, which I read that and I was like, how can you say that when you didn't even report on the side effects?
It's interesting nowadays how I can't remember a time growing up where I remember in a newspaper or even online once, internet was out there with all the different sites having these news flashes of, ASCO article updates, but now it's everywhere. And it's, like you said, very misleading when you're making a statement that's just not true about something that's being reported.
Right. And again, some of it's not the fault necessarily of the reporter. These aren't usually medical people.
Yeah,
but at the same time, if you don't know, don't report it.
Don't report it.
Yeah,
right.
It seems it's a way to get clicks, if you will. Clickbait, right?
Yeah.
Brenna, is that what the kids say?
That is what the kids say.
Okay.
That is what the kids say.
Well, the same thing with
headlines.
with rectal cancer last year when they reported immunotherapy.
Oh, right.
given.
Gosh, yeah. How many patients walk into your clinic demanding it?
Immunotherapy cures rectal cancer. Well, yeah. I mean, if you have a specific genetic change that yields a response to immunotherapy, but you see that, and then you get patients that get excited about the information and want to know more, and but it's just it's not good to report something that's generalizable to everyone when it's not, so but a good article to review, and we'll see what happens in practice if anything changes. All right, well, thanks everyone for joining us on another episode of the Rick and Danny Show.
We actually haven't gotten a dad joke in a while. And when I was at the Beach's office last week, got a lot of requests. So
I don't see his book, though.
Just going to throw that. They all said that. He has a book. I said, all right, no. So I'm just going to throw that out there.
Let me go into my archive here.
Okay. Because the people are requesting.
I don't know who these people are. But
I know you've been busy.
His book looks just like a iPhone. Very interesting.
It's electronic now. There's no more books. But I do have a couple dad joke books. I'm not going to lie. And someone sent me a text message of a bookshelf. I think they went to a bookstore and there was a bookshelf dedicated to dad jokes, which was pretty awesome.
That is pretty awesome. I think we need to bring it back.
All right, this is a good one.
All right, Rick, you ready?
What do you call an angry carrot?
I don't know. Oh, wait. Carrot stew? I don't know. No, I don't know.
A steamed vegetable.
Dang, that's close. Steamed vegetable. Nice.
Excellent.
Not bad.
All right.
We have time for one more?
Yeah.
Let's do it.
It's never good when he pre-laughs.
Well, cat jokes are pretty funny. What do you call a pile of cats?
A litter box?
A meowton.
Oof, that one hurt. That was weird.
I wish we had video back.
That was pretty funny.
I'm going to crawl in a hole. Crawl in a hole right now. I feel uncomfortable.
Now Rick knows why we haven't done dad jokes in a while.
So thank you all for listening. And I think we're going to talk about some more studies coming out of ASCO on the next episode. So thank you all for tuning in, and catch you next time.
Thanks, guys.
It's been so long since they did a podcast. Rick just broke.
Hey,
Rick just trailed off.
We do a podcast every month,
I'll
Brenna. You
talk
make
to you
me come
later.
here and supply me with coffee.
Okay, bye. Love you.
Yeah. Okay, bye. Gotta go. See ya. Bye.
You feel like Alicia. But bye. Love you. Love you guys.
Bye.
What?
Bye.
Did I say that?
Bye.